International. We are recording tonight's presentation. So please know that before we begin the question and answer session, we will stop recording so that we are not collecting or recording any private discussions or questions with Dr. Kenney-Jung. One of the things that Dr. Kenney-Jung mentioned before you all joined is that if he feels like it's a conversation that he needs to take offline and have with you about your child privately, that he will just recommend doing that, and we will follow up with you. We're asking that if you do have a question, to place it in the chat. That way we can prioritize questions in the chat at the end of his presentation. And then after we prioritize the questions in the chat, we will then prioritize questions by simply raising your hand and asking a question. I also have on the call this evening Ashley Genlin, who is a program contractor here at CFC International. She does 10 hours a week with us. And so Ashley, you want to say hi to everybody?
Hi. Sorry, I'm distracted trying to let everybody in.
That's fine. We are very excited to be bringing these webinars to you all here at CFC International. We are very excited by Dr. Kenney-Jung. He has been a member of our medical advisory board since 2019. We discovered Dr. Kenney-Jung for our medical advisory board back in 2019 because he had teamed up with Dr. Renee Pierpont to conduct the seizure natural history study at the University of Minnesota over 5, 6 years ago now. And that was really the moment where we not only identified CFC syndrome as a rare epilepsy or a rare genetic cause of seizures, but also identified some phenotype and variant information about each of the genes that helped us better understand what variants might be more susceptible to seizures. So we are very excited to have Dr. Kenney-Jung with us here. He volunteers all of his time at CFC International. He volunteers so much of his time to meet with our families and to continue research for CFC International or CFC syndrome. So we are very excited and so grateful for the work that he does. I'll tell you a little bit about Dr. Kenney-Jung. He received his MD from Tufts University School of Medicine in 2009. He did his residency in pediatric neurology at the Mayo Clinic and fellowships in clinical neuropsych physiology, pediatric epilepsy, and epilepsy research also at the Mayo Clinic. Following academic appointments at the University of Minnesota and Duke University, he completed a genetics residency at Johns Hopkins University. And he'll be starting his work at the University of Michigan next month, primarily seeing patients with epilepsy, neurogenetic, and neurodegenerative disorders. And tonight, he's going to really share with us identifying factors of seizures in children who have CFC syndrome, not CFC syndrome specific, but helping us really identify and clarify what seizures might look like and when we should be concerned. So I'm going to let you take the floor, Dr. Kenney-Jung. Thank you so much for
Right.
being here, and we'll take questions afterwards.
Well, thank you. Thanks, Tuesday. And I'd like to thank everyone for joining this evening. So a few weeks ago, Tuesday and I were talking, and it was sort of came up that people were actually really interested in maybe understanding a little bit about identifying seizures, like, when you see something, is it a seizure? Isn't it a seizure? How do you know? And maybe also a bit about some of the language that we use around seizures. And as I thought about it a bit, I realized this is kind of an area that as neurologists, I think we probably don't do as good a job with in terms of kind of educating patients, not just about the things that are maybe, at the given moment, okay, your child should take this medicine for this condition or something, but also sort of kind of give a sense of how we get to those conclusions and what that what the thinking process is, what all these terms that we throw around kind of mean. So I'm going to try to get to some of that a little bit. So you can kind of think of this as almost kind of like a user's guide to your neurologist in a way, um, in a sense, I guess. So we're going to talk about, like I said, what seizures are, how we talk about them. So go through some of the terminology, not all of it. I mean, as many of you know, there's a lot of terminology, but I'll try to get the stuff that seems most important. Different seizure types, um, and some examples of different seizure. I have some videos here. The videos that I have, I want to mention that they're all off of everything that I'm going to show you I obtained off the internet. I'm not going to show any patient videos. Um, it just seemed like I kind of wanted to just use things that were sort of in the public domain or publicly available. So I don't know the backstories of these people. I kind of deliberately did that. But I have looked very carefully at these videos to make sure that they're representative. So just kind of a little bit of background here. I mean, as you know, seizures are common in CFC syndrome. About 55% of people with CFC syndrome have had a seizure at some point in their life. Of those, the seizures have tended to be the people who have seizures often have kind of they can have fairly severe epilepsy. About a third have had seizures longer than an hour in their lifetime. About 70% have had an episode of status epilepticus, maybe less than an hour, but still status. Infantile spasms, which is a serious kind of epilepsy that happens in babies, is also pretty common. It depends a little bit on what your mutation is. Uh, Not everybody has the same risk, but that's also a thing, and we'll get to that a little bit more. But clearly this is an issue for for our population. And it's something that doesn't, even though the highest frequency is early in life, there's still a chance throughout the lifetime. And we see this among people even without CFC syndrome. The highest risk time of life is early in life, but then later on in life too, there's another period where the risk of epilepsy goes up. So it's not something that just goes away, um, uh, very early in life. Even with genetic epilepsies, you might think, okay, well, you're born with the condition and then you either have seizures or not. Well, it's not always the case, and you may not have seizures for a long time and then suddenly start having them. And so it's good to kind of have a sense of what they look like and to kind of be at least prepared on some level. Not that you want to live your life in, worrying about this kind of thing, but I would say that feeling a little bit prepared for it maybe will help reduce the worry and allow you to think about other things. So, with that in mind, we're going to talk about different seizure types a little bit. These are the data from our study, and we kind of lump them into these different types of seizures, and I'm going to show you examples of these different kinds of seizures. Um, it can be really difficult to determine what kind of seizure a person's having just by looking at them. That's especially the case with the focal seizures and absence seizures. It's really easy to confuse those two. And we'll look at examples of each of those. But when we're thinking about how to treat somebody, it is pretty important that we make that distinction. Because, for example, I mentioned the difficulty telling absence seizures from focal seizures just by looking at them, because sometimes focal seizures can look a lot like absence seizures, um, depending on the part of the brain that's involved. Um, the medications that we use to treat those two seizure types are pretty different. And in fact, the medicines that we might use for focal seizures can actually make absence seizures worse. And some of the medicines that we use for absence seizures, at least one of them, doesn't work very well for focal seizures at all. So we really want to get it right. And in the course of this talk, we'll touch on some of the ways that we do that. Um, Backing up a moment, just to kind of try to maybe not completely answer this question, but just sort of at least acknowledge it. Um, I think it'd be fair to ask, what is a seizure anyway? You know, we've been talking about seizures. What are they? The best definition I've seen is this statement that it's uncontrolled abnormal electrical activity of the brain that can cause these symptoms, level changes in level of consciousness, behavioral changes, issues with memory, sensory changes, things like that. We usually say that the electrical discharges happen in these kinds of rhythmic bursts. You know, and you see that if any of you have ever seen an EEG, and we'll look at a few. We're not going to do a ton of EEG, but you'll see it. You know, that's the test where you look at brain waves with the little stickies that go in the head. Um, People think of a seizure as being very rhythmic, and they have that characteristic very often, but there's a lot of rhythmic brain activity that isn't seizure. And so the definition gets a little bit mushy when you start to really drill down on it in a scientific way. But for our purposes, just calling it uncontrolled abnormal electrical activity of the brain that can cause changes in level of consciousness, behavior, memory, sensations, feelings, emotional symptoms sometimes. That's a good definition for in terms of talking about disorders. And that's really the definition that epileptologists use. So we kind of talked a little bit. I mentioned focal seizures earlier. There are kind of these two families of seizures, focal seizures and generalized seizures. I'm starting with generalized seizures. Generalized seizures are usually considered to affect the entire brain. And so when you see a person having a generalized seizure, it's often affecting their entire body or their level of consciousness. Focal seizures may or may not have that effect. Focal seizures usually at least start in one part of the brain, but they might spread further. So you'll hear us use this term secondary generalization. That's where you have a focal seizure, a seizure that starts in just one part of the brain, just a focus, and then it spreads throughout the brain. That's a seizure that starts focal and ends up generalized. Among the generalized seizures, we have these terms that you've probably heard before. Absence seizures are generalized seizures. Generalized tonic-clonic, which I think many people will know what those are. Those are kind of the big seizure. People use the term grand mal, where your body gets stiff and then you have jerking of the arms and the legs. Spasms, and we'll look at those. Atonic seizures, drop seizures. We'll see a few of those too. And then myoclonic seizures, which is where the body just has a single lightning-like jerk, kind of like a sleep startle, but a sleep startle isn't a seizure, but it can kind of look like that. Focal seizures, on the other hand, the way that they look really depends on the area of the brain that's involved. So if the focal seizure is just happening in the part of the brain that sort of moves the left arm, you know, in the right motor cortex, you might just have jerking of the left arm, and that's the seizure. Now it might spread, and then you might get a change in that, but the symptom of the focal seizure is going to have to do with the part of the brain that's involved. And that can be a big problem, actually, because that means that you could have a focal seizures looking many different ways. And if it's repetitive jerking of the arm, I mean, that's pretty easy to see. But what if I had one patient who was having focal seizures uh, the uh, all from the very tip of her left frontal lobe, and her seizures had more of an emotional component to them. And you know, they were real seizures, and she ended up doing well with treatment. Um, but it can be really hard to sort that out. So that's why focal seizures can be pretty tricky. And we've kind of put them into two buckets: focal seizures with impaired awareness. Those are kind of, you'll hear some people call those complex partial seizures. That's kind of the old school way of calling them. And then focal without impaired awareness. And some people will call those simple partial seizures. Focal with impaired awareness just literally means that it's just a focal seizure that affects your level of consciousness, you know. These are the ones that can look like absence seizures. Somebody has a focal seizure, they're kind of spaced out. And we'll see some examples of those. Whereas without impaired awareness, that might be the person that I mentioned earlier. They might just have jerking of one arm or stiffening or something, like stiffening of one limb or something. And they might be awake through it, but it's still a seizure. But it's not affecting their level of consciousness. Generalized seizures and focal seizures, a lot of medicines that work for generalized seizures work for focal seizures, although not everything. Medicines that work for focal seizures, many of them, but not all of them, there might be some overlap between what you use for generalized and focal seizures. Levetiracetam or Keppra works for generalized and focal seizures, at least to a certain extent. But and so you'll see that one kind of thrown around a lot, but some medicines are used more for one than the other. And so that's why it's important to kind of know what you're dealing with. Here's another word. This is an important word. You might have heard it before, but it's one that we're gonna bring up. This is the word semiology. And that just means the appearance of the seizure, what the seizure looks like. The semiology of the seizure semiology is what it looks like. When you're looking at the person, what do you see? And that description is the description of the semiology. So seizure semiology, the appearance of the seizure, that gives us really important information about where the seizure might be coming from. Gives us an important information about whether or not it's going to be focal or generalized, you know. Um, when we're talking about seizure semiology, we always want to know what the first few seconds look like. And so your neurologist is going to ask, if you're describing a seizure, they'll say, okay, what's the very first thing that you noticed? What's the first thing that you saw? How do you know that a seizure is coming on? How do you know that what's the very first thing you see or that you're aware of? And why is that? Well, because uh, first of all, if that can give us a sense of where the beginning of the seizure might be. And second, it might affect, you know, issues of safety or things like that. But remember I mentioned earlier about focal seizures, how they could kind of spread and go to different places. Um, if you're thinking about treatment that's going to involve stimulation or surgery, it's absolutely critical that you know where it starts. But even if you don't, you're not thinking about doing something like that. It's very, very useful to have a good sense of where the seizure is coming from, just to sort of, if only just to know that it is focal, and also to know where to look on the MRI, right? Because sometimes if you're like, well, the radiologist says this MRI is normal, and you're like, yeah, but I think this person has seizures that are starting, in the right hippocampus, and you look closely and you're like, oh, sure enough, that's where they are. And why did I think that? Because, they have this little bit of a burning smell at the beginning of their seizure, and then they have these certain characteristics, and it's like that can give you a hint about where the problem's coming from. So those first few seconds of the semiology of the appearance of what happens in the seizure. That's really important. And so I kind of gave just kind of a description, an example there of what the semiology is. And that word is so important, and it gets thrown around so much. Maybe not during clinic visits, but certainly in the documents and so forth. And also probably when you Google these things, you come across it. So I want to be really sure that we brought that out there. Um, so how do you know if something's a seizure? I just told you that focal seizures can can look different depending on what part of the brain is affected. How do you know? Well, the thing that helps me the most is to know is to get a sense of how stereotyped an episode is. So if someone's telling me that they have an event and it always looks the same, it always starts exactly the same way, maybe it ends different ways. Maybe sometimes it turns into a big seizure and sometimes it just kind of peters out, but it always starts the exact same way. That you start to suspect a seizure in that case. Because if you think about it, a seizure is really kind of it's an electrical circuit that's kind of going wrong. So if you stimulate that circuit, you should get pretty similar response each time. Also, there are certain semiologies, certain seizure appearances that are common. Sometimes I can hear a description or see a video and kind of feel like, okay, this is this is very consistent with a seizure. Sometimes I can hear a description and be like, no, I don't think that's a seizure. There are certain things that a seizing brain really can't do. And there's certain things like I sometimes I'll hear a description, I'll say, no, that can't possibly be a seizure based on the description because that's just not the way that a seizure could propagate through the brain. Um, But that stereotyped aspect of it is important. Now, that having been said, a person can have more than one kind of seizure. So maybe sometimes they have a seizure that starts with like a smell of burning, and then, their head and eyes sort of turn a little bit to the left, and then, the left arm starts to stiffen or something like that. Maybe they have that one kind of seizure, and then they have another kind of seizure where they stare and their eyes flutter and they're staring straight forward. Two completely different things. Maybe each one kind of starts the same way. So each one kind of starts in its own way, but you have two distinct items there. That happens also. People can have multiple different kinds of seizure. Some people can have generalized and focal seizures. Um, and so that's kind of the thing to bear in mind. But generally speaking, when I'm thinking about trying to figure out if something's a seizure, I think about those first few moments. I think about how stereotyped it is, and um, I think about kind of whether it sort of fits into some of those families of seizure that we talked about. Not every seizure does. I mentioned that young woman that I saw who had the anxiety kind of seizures. They were actual seizures, and she responded well to anti-seizure medicine. She did not respond to uh, psychiatric treatment. She was having real seizures on the EEG, but uh, you wouldn't really be able to fit her easily into kind of like it's not a type of seizure that I'd ever seen before, but it certainly happens and it's documented in the literature. But, with focal seizures, we have to kind of be prepared to be surprised, I guess is what I'm saying. So here's just kind of like a little glossary that I sort of put together of like some of these words that we throw around. And I think some of them you hear so often, you don't really even kind of think about what they mean. I think about like words like tonic and clonic. What does that actually mean? Well, tonic means stiffening. You can have tonic stiffening of one limb, or you can have tonic stiffening of the whole body. And clonic is jerking movements. So when we talk about a generalized tonic-clonic seizure, we talk about GTCs and we all kind of know what it is, but what the term actually means, the body stiffens, and then you have that jerking movement of the arms and the legs. And we use generalized because it involves the entire brain and therefore involves the entire body. I mentioned secondary generalization. That's where you have a focal seizure that spreads throughout the brain. So it's still a focal seizure, but then it turns into a generalized tonic-clonic, or it turns into a generalized seizure. And usually with those, we treat them like you would treat a focal seizure because you want to start it at the very beginning. I mean, you want to stop it at the beginning, right? You want to stop it within those first few seconds. So you just use the usual treatment that you would use for a focal seizure, even when you have secondary generalization. When we talk about spasms, we're usually talking about this particular movement where the body kind of flexes forward and the arms extend. And I'll show you some videos of those. Myoclonus, I mentioned, is kind of like this kind of body jerk. Usually it's the whole body, but not always. Most of the time, myoclonus isn't a seizure. You know, that feeling that you get as you fall asleep and sometimes your whole body jerks and it wakes you up. It's really annoying. That's we call those sleep startles or whatever. That's not a seizure. It's myoclonus. But people can have seizures that look like that, and we call those myoclonic seizures. An atonic seizure is where the whole body drops, or sometimes just a little bit of a loss of tone involving a little bit of a drop of the head. And they can be really subtle. The classic one is where somebody just falls to the ground, but sometimes it's just sort of a little bit of a drop of the head, often with the eyes slightly deviating upward. They sometimes the video is really good for those a lot of times. Now, absence seizures. This is an area where we get into trouble sometimes. This sort of this sort of appearance or semiology of staring, being unresponsive, sometimes having some other things going on with eyelid flutter sometimes, or repetitive, some mouth contractures, sometimes movements of the hands. These absence seizures, we usually use that word for seizures that look like what I just described, but are generalized. Now, I mentioned that people can have focal seizures that look just like that. And sometimes people can have both focal and generalized seizures. So you can imagine it can get a little bit dicey if you have someone who has focal seizures with impaired awareness and also has absence seizures. You might be looking at these are the sorts of circumstances where we have to really think about what the best kind of drug, what kind of drug we should use here. And sometimes it can be a bit of a moving target. Eye deviation, that's where the eyes turn toward a particular direction. We'll say leftward eye deviation or upward eye deviation. You'll hear that term thrown around a bit. An aura is a sensation that indicates that a person is going to have a seizure. I mentioned earlier the idea of a person having a seizure where they get a sense of like a burning smell or an odor or an emotion, or sometimes they can't even put words to it, but they're like, I'm going to have a seizure. Sometimes they know several minutes beforehand. They're like, I'm going to have a seizure. I need to get someplace safe or whatever. That's what an aura is. And then gelastic seizures and dacrystic seizures. Dacrystic seizures have the appearance of crying. Gelastic seizures have the appearance of laughing. They aren't actually laughing or crying. It's a type of seizure. They're pretty rare. They can be difficult to diagnose. It can be very tricky to treat those. Seen I've seen it go both ways. I've seen people come in where um, there's a belief coming in that they have gelastic seizures and they do not. On the other hand, I've definitely seen people with gelastic or dacrystic seizures too. And the EEG can be a little bit ambiguous for those too, so they can be very challenging. But gelastic seizures mean a seizure that looks like laughter. Dacrystic seizure means a seizure that looks like crying. A lot of times what helps us out with those is that the laughter or the cry is quite stereotyped. Um, and so that can be kind of a hint. Again, remember I said it's sort of like you've got sort of a circuit that's being triggered here. And so just as, in a in a computer or a piece of electronics, when you trigger a certain circuit, a specific thing happens. That's kind of like what you expect to see with a seizure, much of the time. People are complicated, so. So, most important thing when trying to sort this out is the history, the description of the seizures, the patient's entire history, of course. But we're concentrating on seizures today. A very careful description of the seizures. Again, especially those first, as early in the seizure as you can remember. A video is always great. It's very hard to get a video of the first little bit of the seizure, but anything that's there can help a lot. Um, Exam is good. Going back to history real quick, even when I have a video, I usually ask families to describe to me what's in the video, or describe to me what they usually see, to make sure that I'm noticing the right things. It's very possible that there's some aspect of the seizure that, it might even be perfectly visible in the video, but I'm not. It's if the family draws my attention to it, it'll help me to attend to it a little bit. So I like to go through the video with people and sort of be like, okay, so let's talk about it together. Um, Exam, of course, that can give you a lot of information for obvious reasons. EEG, I think, is something that many people in this audience are going to be kind of familiar with, the little stickies that go on there. What they're doing with that, they're measuring voltages on the scalp, of course, and those scalp voltages can give you some sense of what um, of certain things, certain tendencies that the brain might have. It's a very, very blunt tool. It's not perfect, but it's what we've got, and it's safe. It's relatively non-invasive. It can be very annoying. And so, not everybody tolerates it, but it's certainly not, the scalp EEG is a pretty benign test for people who can tolerate it. Um, the information that we get from that is kind of like we can learn about somebody's tendency towards seizure. Like we can look at the EEG and say, okay, we're seeing a lot of these markers, spikes, sharp waves, things like that. There are other words that we use, and those just tell us there's a tendency towards seizure. Sometimes if we want to tell some information about the seizure itself, we might try to catch a seizure on EEG. Sometimes that involves coming into the hospital for a prolonged EEG to try to capture an event, or taking an EEG home. Those are both kind of annoying processes, but they can help us to, capturing the seizure can help us to tell, first of all, whether a seizure is focal or generalized, which um, can make a big difference in your treatment, as I mentioned. Because like I said, sometimes it's hard to tell just from the description or even from a video. Sometimes it's even hard to tell if something is a seizure. I mentioned the person earlier with emotion seizures. Just by description, if you said, are these seizures? I'd say, well, probably not. But sure enough, they were. And like I said, she responded pretty well to treatment. Um, so these kinds of tools can really help us make those distinctions. The important thing is we want to treat everyone who is having seizures, we want to give them the best possible treatment. We don't want to be giving anticonvulsants to people who don't need them. The drugs are certainly safer than they were 50 years ago, but you don't want anybody on drugs that they don't need to be on, right? I mean, every drug is a new disease in a sense. And so you want to minimize the drugs that somebody's exposed to that they don't need. So knowing if something is a seizure or not, and knowing what the right kind of medicine to give for it as best we can make that determination is what these tools are really for. Um, Not there. I mentioned about tendency towards seizure. I can give evidence about tendency towards seizure. A normal EEG or an EEG that doesn't show spikes or sharp waves or clear tendency towards seizure doesn't rule out that someone might be having seizures. It just it can help rule it in, but it doesn't necessarily rule it out. It depends on history, and exam is really important to that. So I wouldn't want somebody to say, okay, well, they had a GTC last week, but we had a normal exam today, so probably it's fine. A normal EEG today. The EEG is like I said, it's a very blunt tool and it needs to be interpreted in context. MRI can give us a sense of whether there's an anatomical cause for seizures, but a lot of people who have epilepsy have normal MRIs. That's not uncommon. Many people with CFC syndrome have MRI abnormalities or MRI findings, but they aren't necessarily things where you'd say, okay, this is clearly the cause of the seizures here. We see things like white matter differences, alterations in what's called the corpus callosum, which is kind of this big, kind of like part of the major wiring for the brain. Sometimes that's shaped differently, but and that's more common in people with CFC syndrome. But there are actually people walking around out there with normal intelligence and no seizures who don't have a corpus callosum. So it's pretty nonspecific. And a lot of times we see stuff like that in CFC syndrome, but we do also sometimes see malformations or dysplasia, which is where you have brain cells where they shouldn't be, and those can cause seizures. So the MRI is still very useful, especially if you have focal seizures. But it's certainly not a silver bullet for this kind of thing. So I'm going to get into some of the example seizures to start with. Just kind of some, just but bear in mind some of the stuff that we just talked about, and see if it applies. See if it makes some of this make sense. So this might be a patient that we see, not necessarily with CFC syndrome. This would just be like somebody who might come into my office. 5-month old with some developmental delay, no risk factors that we're aware of, normal exam. And they're having these spells where their body flexes forward and their arms extend. And they started a month ago, and as very often happens, this is diagnosed as reflux. It's very common that this particular kind of seizure is thought to be reflux, but it isn't, as many of you know. This is infantile spasms, and I'm going to show a video in a moment that I found on YouTube of this. This infantile spasms can result from many different causes. Um, Either birth injury, genetic disorders, or what we say idiopathic, meaning there's no known cause for it, like they just happened. Um, we treat these usually with these medications, vigabatrin or ACTH, and some of you will have had some experience with those medications. We don't usually use them very often in other contexts than this. Um, if there's some evidence that early treatment, when successful for infantile spasms, um, can have better outcomes, but it's not clear how well that research applies to CFC syndrome in particular. We do know that some people with certain mutations associated with CFC syndrome are at greater risk for this kind of epilepsy. Um, these seizures are unfortunately related to an increased risk of motor impairment and other kinds of seizures and delays further down the road. So this is something that we usually try to get on top of. And that's why it's sort of a problem that they're kind of subtle. I'm going to show you this video here, and you're going to notice um, this if you were just looking at this and say you're uh, you know you don't really know what you're not a neurologist, you could see how somebody could see this and think not realize that they're seizures. I'll give it a moment. As I said, this was from YouTube. Here it was. That was it. Then you'll see another. What I would mention though is that these are very stereotyped, right? The same thing pretty much happens every single time. But you can see how somebody might think, okay, this is some kind of reflux thing or something like that. But those actually are infantile spasms. And this is kind of the classic appearance with both arms stretching out. You know, there's kind of a facial grimace. And then they happen in clusters, often about 2 clusters per day. Um, and so this is something that I think pediatricians are more aware of this now than maybe they used to be, um, 20 years ago or so. But I still see, it's still pretty common for me to see people who are coming in, a month or so after these started, with with a bunch of like antacids already having been trialed. But again, the thing that I'd sort of draw your attention to, the thing that might make you think these are seizures, even if you didn't know about infantile spasms, is that they all look so similar to each other, and that gets that kind of gets your attention. Um, I'm not going to show a lot of EEG, but for infantile spasms, because I kind of mentioned that this is a very this is a type of epilepsy that I think, or type of seizure pattern that I think is maybe more strongly associated with some mutations in CFC syndrome. Uh, People will hear the term hypsarrhythmia. Hypsarrhythmia is this EEG pattern that you see up there that's kind of disorganized. Um, so you can kind of compare the one on the bottom, the that's normal, with the one on the top, and you can see that it's very there's really even if you don't know how to read EEG, you can see that there's pretty clearly a difference between the one on top versus the one on the bottom, and that kind of disorganized, chaotic pattern that's that word hypsarrhythmia. And so again, this is one of those words that I think gets thrown around a lot, but uh, doesn't get explained very often. And hypsarrhythmia is just the word for that EEG pattern. And again, I wanted to mention it because I think this is something that that people in our specific community will. This is a term that many of us will have heard. And then during the spasm, there's this kind of like period where the EEG kind of gets a little bit quieter almost, and it's called an electrodecrement. That's another word that gets thrown around. I'm not going to spend too much time on this, but for but I feel like I should mention it just because I wanted to cover some of this language that gets tossed around. Next example. This would be an example of someone who comes in with multiple events that could be seizures. A 30-month-old child, they have some delays, and then there are a few different things that they're doing. They have these events where they have these head drops. Sometimes they fall to the ground. It's really quick, and the child's completely back to normal afterwards. Then these events, well, while sleeping, where the eyes open, there's a little bit of stiffening of the body, the arms extend. Sometimes the child wakes up, sometimes they don't really wake up. Sometimes they pretty much seem to sleep through it. And then staring spells. Remember we mentioned how that could be absence seizures, could be focal seizures, and you could have both focal seizures and absence seizures in the same person sometimes, this would be the kind of person where you would worry about that. So this is a person with three distinct types of episode. And so one question that I often ask of families, okay, how many different kinds of episodes are there? And I say episode because sometimes people will have, I've had patients with focal seizures and tics, or a movement disorder, and so something that is a seizure, and then something that also that looks kind of seizure-like but isn't. And so I want to try to get all of that information. So that's why I use words like episode or spell, so that we don't make the mistake of just assuming that someone's having seizures. Because like I said, we don't want to be throwing medicines at someone that they don't need. In this case, this person is having three distinct types of seizure. Um, these sort of drop seizures, remember the word, we call those atonic seizures. Um, you can see it's fairly subtle here in this young person. Um, see, and if you just saw the one, you'd be like, huh, okay, all right, this just goes on repeat, but you'll have to they happen repetitively. They happen enough. You start to get worried that you're dealing with a seizure. Babies do all kinds of things, but if you're seeing the same thing over and over again, you have to worry about seizure. Tonic seizure. This is quite an old video from an old neurosurgery instruction. Um, uh, this is a fairly dramatic example. But remember the events that our patient was having from sleep of stiffening. Um, the example that you're about to see here is pretty dramatic. Um, Although this is a type of seizure that you see from sleep among many of these people. But sometimes they can be very, very subtle with just a little bit of stiffening and eye opening from sleep. And that's one of the good things about doing the prolonged EEG, because you can capture those. Because those seizures from sleep, we believe that those can be somewhat disruptive to sleep, and so we try to get rid of those if possible. And then atypical absence. These can be really hard. It can be really hard to tell when someone is having an atypical absence seizure. Um, I'm going to draw your attention to certain specific things here. This person has episodes where they sort of have kind of lower tone. They don't really respond well, and you can see that rhythmic twitching of the eyelid. And then they sort of like perk up a little bit. Sometimes people don't completely lose consciousness during an atypical absence, but their level of consciousness is certainly somewhat impaired. And so seeing all those different seizure types together, especially where there's some degree of developmental delay, um, the term that's often used is Lennox-Gastaut syndrome. And Lennox-Gastaut syndrome is not really a diagnosis. Lennox-Gastaut syndrome is more like a description of a syndrome where you can have multiple seizure types and also some developmental delay. Uh, it can be caused by many different things. So there are many different diagnoses, genetic diagnoses, birth injury, really all of the things that can cause sort of be associated with developmental disability and seizures you can see this sort of Lennox-Gastaut type pattern very commonly. So So it's not really, we say Lennox-Gastaut syndrome, and I think that's appropriate, but I want to stress that it's a pattern, not so much a diagnosis. Um, and people with this sort of a picture can have many different kinds of seizures, all in the same person. And they may need multiple medicines to control those. And often it's a moving target. Often a medicine will work for a while and then it won't work so well. And then you wean that medicine off and you try to start a new one. You're always trying to like, improve their treatment and improve their therapy. But it can be quite stressful, keeping up with all of these medications and so forth. And so it's a very uh, it's a complex sort of picture. But that's what that term Lennox-Gastaut syndrome means. Not everyone with Lennox-Gastaut syndrome is going to have really difficult to control epilepsy. I've definitely had people where, we get them dialed in pretty well and they do great. So I would never say, and sometimes it takes time, you know, sometimes sometimes it does take time, but I would never say, okay, well, it's refractory epilepsy and that's all. We're always trying, but it can be a long process. This is another example. I mentioned focal seizures earlier. I want to show you some examples of focal seizures. Um, this would be a child who has episodes where their head and eye turn to one side. They have these sort of chewing movements of the mouth, and you'll hear different words for that. Oral automatisms is the word that I tend to use when I'm writing notes. I use the phrase oral automatisms. It's really common for people to refer to this as lip smacking. I've never really liked that phrase, but you will hear it. And it just means the repetitive mouth movements that you'll see in our next two examples. And then this person also has flexing of the arm, which is also really common with focal seizures. So this would be an example of focal seizures with impaired awareness. Um, and with these kinds of seizures, usually the person will stop what they're doing and they'll start going through their process, their seizure. The seizure will go through. Sometimes it will predictably move from one thing to another. A person might have an aura, smell something or a sensation, and then they develop the oral automatisms, the mouth movements. Then they have their eyes turned to one side and their head turned to one side and their arm flex. And that would be a pretty common pattern. But it's not the only pattern that there is. Like I said, it really depends on what part of the brain is involved. Um, this is a common pattern for hippocampal seizures, which this baby here may have something like that, or probably has something in the frontal lobe, actually. This is a dramatization of a focal seizure, but it's a good one from the Epilepsy Foundation of Canada. Um, and again, you'll sort of see this kind of stereotyped pattern. This would be sort of whatever this person was doing, they stopped doing it. They had behavior arrest. And then the seizure kind of moves through its circuit, causes those mouth movements and that repetitive hand movement. Now, looking at that, you'd say, okay, that's pretty strange behavior right there. How do you know that's a seizure? Well, one reason is just because certain seizures, temporal lobe seizures, can look like that. But another reason, even if you didn't know how temporal lobe seizures look, if the person has every time they have an event, it looks just like that, and they go through the same process, you really have to worry about seizure. And I hope I've probably like said that too much now, but that the degree to which um, uh, we look for that kind of stereotyped pattern, I want to kind of stress that a little bit in terms of identification, because like I said, focal seizures can be really hard to identify otherwise, because really they can look a lot of different ways. Um, Again, I don't want to really drill down on EEG, but I think you can see that something changes right where I put those red arrows. Um, and it changes just in the one part of the EEG. And eventually it kind of starts to spread. But you can kind of see the seizure at its start, and you can see that it's just in one part of the brain. And then it kind of starts to move to other parts. And that's really what focal seizures do. Now, focal seizures with impaired awareness can look like absence seizures. So, what's the difference? It can be hard to tell. This is from the same group. I mean, it can be hard to tell by appearance, but by EEG and by what's happening in the brain, it's a generalized seizure, not a focal seizure. And so, we've already seen one absence seizure. That's an atypical absence. This would be more of this person is going to demonstrate a typical absence seizure. Right here, again, this video comes courtesy of the Epilepsy Foundation of Canada through Toronto. And you can see some behavior arrest. In this case, this person has relative preservation of tone, so their head still stays upright. There's this little kind of vague fumbling movements of the hand. And then they go back to doing what they're doing like nothing ever happened. That'd be more like a typical absence seizure. Um, Now, this is why I showed you the EEG earlier for that focal seizure. You can see the difference between the focal one on the left and the absence on the right. See, the focal one is you're just seeing those little up and down seizure patterns in that one part of the EEG, but over on the right, you're seeing it affecting the whole brain. Even though just by looking at the person having the event, you might not know what kind of seizure they are. However, based on the fact that they're very stereotyped, they're happening repeatedly, um, based on how they look, you would probably be able to tell, okay, these are some kind of seizure. You know, this person clearly needs an EEG. So even if you couldn't figure out just by looking at them whether it's focal or generalized, you would know that you need to work them up. And eventually you'd figure it out and make sure they got on the right drug. But the medicines that you'd use to treat the person on the left would be different from the medicines you'd use to treat the person on the right, even though even though they might look quite similar. Another example, I don't have a video for this. I wasn't able to find a good one that wasn't a patient of mine, but this is just something that can happen. Like a person could have thrashing movements from sleep. It's very common when people have these kinds of seizures that they have diagnosis of night terrors or pseudo seizure. But frontal lobe seizures can do this. Remember, I said focal seizures can look like, depends on what part of the brain is affected. Sometimes seizures in the frontal lobes can look like these thrashing movements from sleep, and they can be hard to see on EEG. But the EEG is still really useful because we can see that they come right out of sleep. We can see what sleep phase they come out of. And we can use the video to make sure that the movements are very highly stereotyped, which for a seizure they should be. They are often misdiagnosed for those reasons that I just mentioned. A lot of times people are like, well, this is like attention-seeking behavior or it's some kind of a sleep disorder. The EEG can tell us that. The video EEG can help us understand that even when we can't see really clear seizure discharges, just by looking at the video, seeing what phase of sleep they come out of, that can give us a lot of information, even though the information is maybe a little less direct than it is in other cases. But again, that stereotyped nature of these events really helps us out. Um, a person with these kinds of focal seizures from sleep, what we call hypermotor, maybe they always get up They roll out of bed, they roll over to the left, they put themselves into a seated position, they wave their arms around, and then they get back into the bed. That's one I've actually seen. It was indeed a seizure. And it was the stereotype nature of that. They always did the exact same thing that really helped me understand what I was looking at. So just to kind of review, appearance of seizure depends on what region of the brain is involved. Um, but we are helped out by seeing certain semiologies. We are helped out by the stereotype nature of seizures most of the time. Again, you don't want to generalize. You don't want to say everybody is exactly the same, but I'm giving you kind of the rule of thumb that neurologists use. Um, and It's stuff we kind of have drilled down on. And then, so what do you do with this information? Well, videos help. Try to get it as early as possible. Seizure diaries are good. They can tell us how often a seizure is happening sometimes. A good thing to think about is how many distinct events there are. I wrote seizures, but it could be that a person could be having spells that, they might have one spell, one episode that is a seizure, and one episode that, like I said, is a tic or a movement disorder or something like that. Something that isn't seizure but might be treated, although in a different way. So kind of think about, okay, well, they do this and they do this and they do this. So they have three distinct kinds of events. And, they have this many per week of the first one and this many per week of the second one. That's a really helpful way to kind of conceptualize it. And then, I took us through the sort of the language that we use, focal, generalized, gelastic, dichristic, atonic, things like that. I wanted to I wanted to do that because, like I said, I think it's important that patients kind of know, and families, people should know what the what the words that we're using mean. Because I mean, the purpose of language is communication, right? But that having been said, if you're talking to a neurologist for the first time, I would say don't use the lingo. Just describe what you see. For fear that the neurologist might get bogged down and make the wrong conclusion. Like if someone comes in and says, okay, well, um, you know, my child is having absence seizures. If the neurologist isn't really careful to kind of ask, well, what does that mean, and do an EEG and things like that. If they were just a treat for absence and it was actually focal seizures, it might not work very well. And so, it's good to just describe exactly what you see, There'll be, you can say my child, when they're having an event, they'll be, sitting there doing whatever they're doing, writing their homework or whatever, and they'll stop, they'll pause, their head will dip a little bit, their eyelids will twitch, and then 4 seconds later, they'll be back to doing what they were doing like it never happened. As opposed to saying absence seizure. Even though you know the word, even though you know what it means, probably better than most neurologists, to be honest with you. Um, it's better to just uh, it's better to just describe what you see, um, just to be sure that no mistakes get made. So again, the way a seizure looks, with the way an event looks, is really important to determining what kind of event it is, what kind of a seizure, if it's a seizure, and that in turn helps us know whether or not the person needs anticonvulsant medicines, anti-seizure medicines, and which ones they might need. As I said, the stereotype nature of seizures is part of how we try to identify them. Video is very helpful. Um, Again, you don't want to generalize. People are complicated. And so you don't want to go in saying these are rigid rules that you must always follow. But I wanted to kind of give you a sense of how, as epilepsy physicians, as an epileptologist, how I kind of approach approach these questions of seizure identification. So that's my last slide. We went a little bit over. I'll start going through questions if that's all right.
Wonderful. Thank you so much, Dr. Kenney-Jung. Would you like me to read the questions to you, or do you feel comfortable sorting through them on the chat?